foot ulcer in a 2-year period is nearly 3 times that of treating a cancer patient. So that we know that these are a significant draw on medical resources for our patients and our hospitals and clinicians. The development of foot ulcers is typically multifactorial, but the main reason that these develop is because of neuronal damage. So we know that patients with increased blood glucose levels that are sustained will have damage to the nerves of the lower extremity, primarily because the smallest nerves are located in the feet. And we see this neuronal damage because high glucose levels are very caustic to the myelin fibers that are the protective coverings to our nerves. So patients will develop neuropathy, so complete lack of sensation, and possibly even painful sensation, burning, tingling, and numbness in their hands and in their feet. And we see this to be problematic because when patients lose this protective sensation, they lose their response mechanism to trauma. So patients I've seen walk down blacktop driveways in the middle of summertime and get third-degree burns. I've also seen them fall asleep close to radiators and get burns of their feet that way. I've pulled pins, toothpicks, pieces of glass out of bottoms of patients' feet. And oftentimes they don't realize that they've had an injury until it's almost too late, until infection sets in, they see drainage on their sock, or they smell an odor, or their family member alerts them to them having drainage or odor or swelling or redness of their foot. And probably the most severe case I've ever seen of this, I had a patient years ago. I was called into the emergency department on, and he had necrotic toes due to gangrene, and he had fallen asleep, and he woke up, and his dog had actually eaten his fourth and fifth digit, because while he was asleep, the dog was licking it and trying to take care of the injury. And unfortunately, patient had to go to surgery for reconstruction of this injury. So we want to remember too that motor nerves are also myelinated. So they are also affected by high glucose levels. And when these small little motor nerves in the foot, especially the ones that innervate the interossei muscle in between the toe bones, we can see abnormalities in structural and mechanical mechanisms of the foot as well. So patients could develop hammer toes, bunions. These are areas that have increased pressure. We can see breakdown skin, pre-ulcerative calluses and corns can develop. We also can see abnormalities in the patient's gait and balance. So they can be apt to more falls, with their cadence during their gait is a little bit off, and we can see increased pressure points in already vulnerable tissue areas that can lead to callus formation. Now, again, keeping in line with that kind of cancer thought process, when we see a callus on a plantar surface of a diabetic, we should equate that to the same thing as finding a lump on a patient's breast. And it really needs to be completely interrogated, and we really need to see why they're developing, what's underneath that callus, and really investigate what's going on with this patient. The autonomic nervous system is also affected by diabetes. We can see microvascular dysfunction, small vessel disease in the foot. This will contribute to problems with patients where they will get lack of blood flow to the lower extremity. We see lack of oxygenation. This will not only cause the tissues to be more vulnerable to mechanical stress, but also cause a problem with healing and limitations in healing. So once a patient develops a diabetic foot ulcer, their failure to heal could be contributed by this microvascular disease as well. So when we think about the pre-pandemic model of diabetic foot ulcer management, typically we would see patients weekly at our offices, at our wound care centers. We'd do a thorough workup on them, take photos, take measurements, do aggressive debridements, offload them appropriately, change their dressings frequently, and really, our idea pre-pandemic was primarily to heal these wounds as quickly as possible. We would also utilize hospitals frequently for hospitalizations, for medical management, IV antibiotic, invasive surgical procedures, also for testing. Our hospitals house our vascular assessment equipment, our imaging such as MRI and X-ray, our laboratories. So we wouldn't hesitate to refer patients to these departments within our hospital. And then we also would continue care oftentimes post-hospitalization in a skilled nursing facility or rehab facility. And this was sort of our normal pre-pandemic model. Now, COVID-19 hits, and now we're kind of operating under this pandemic wound care model that's quite different. What we've seen post-pandemic or at the peak of the pandemic is reduced outpatient wound clinic hours of operation. So wound care centers, offices, hospital departments are limiting their hours which they service patients. Often this is because clinicians are deployed to other areas of the hospital, either to the emergency department or the ICU to help to care for those seriously ill coronavirus patients. And we see our patients sheltering in place. They're staying at home. They're not able or willing to come to the hospitals or our offices for care. They're scared. They don't want to be exposed unnecessarily to the virus. And so they're staying home and they might not be seeking the needed care that they would have typically. We're also seeing limited access to hospital resources. Some of the departments that we mentioned, the lab or MRI or X-ray, aren't open and aren't available for patients as much as they were prior to COVID. And we've seen a hold on elective procedures. So oftentimes we might go in for a debridement or another elective procedure for a patient. We're not able to do that because we're trying to reserve resources for the very sick, hospitalized coronavirus patients. We're seeing an uptick in telemedicine, which is great on one hand because we can, have an open dialogue with our patients, but there are certain things we can't do via telemedicine, and offloading is a tricky one. Debridement is also very tricky. Some of our vascular assessments and X-rays and those sort of things are very difficult to do, of course, via telemedicine. And we're seeing an uptick also in our reliance of home healthcare services, both with nursing and clinicians. Interestingly, Tissue Analytics did a study where they looked at the wound volume in March of 2019 compared to wound center volume, patient volume in March of 2020. And what they found is that there was a 40% reduction in the total amount of visits this year in March compared to last year. So we know that patients aren't getting the care that they need, and we have to find ways to overcome this. Initially, the pandemic model was to help conserve hospital beds, again, for the very sick patients battling with the novel coronavirus, to conserve PPE and other resources to help to treat these patients. But what we're seeing, and now that we're kind of on, the downward spiral during this pandemic model, is escalated severity of diabetic foot ulcers. We're seeing increased emergency room visits in this patient population, more hospitalizations, and unfortunately, more amputations. And that's terrible because that's what we're kind of in this business to prevent. And just this week, I saw 2 patients in my outpatient wound care center that had both not gotten wound care for the past 3 months because they were afraid to come to the hospital. And unfortunately, their wounds had deteriorated so badly, they were so infected, they both ended up in the hospital. And today, after I'm done presenting this webinar, I have to go up into the hospital today to amputate one of the patient's toes. So, I mean, it's happening personally in my clinics, and I'm sure you're seeing it in your clinics as well. So we know that information on the coronavirus continues to develop pretty much daily. We're learning about all sorts of ramifications, systemic ramifications of the disease. Some colleagues and I were joking, is our only certainty with the coronavirus uncertainty, and perhaps it is. But we are learning daily how patients are reacting to the virus and what we can do as clinicians to help our vulnerable patients. And the first cohort of patients in the US that were reported with coronavirus came out of the Seattle region. And there was a recent publication in the New England Journal of Medicine that looked at this patient cohort. And what they found is, of the patients that had the coronavirus infection, chronic medical illnesses were very common. And among the very critically ill, 58% of these patients had diabetes. And they also had other comorbidities such as coronary artery disease, obesity, and it put them at risk for increased morbidity and mortality from the coronavirus. So these are the patients that we're seeing regularly in our wound care centers. So they are at increased risk for complications for coronavirus. So we have to find innovative ways to continue to care for them for their ulcerations without exposing them to increased risk of developing problems for coronavirus. So if we look at the diabetic foot ulcer algorithm, and we'll talk a little bit about how these things were accomplished prior to COVID and how we're now accomplishing them in dealing with the COVID pandemic. Pre-COVID, again, we were really focused, our primary wound care goal was healing prior to COVID. With the pandemic, what we're really trying to accomplish is keeping these wounds stable, keeping them from deteriorating, and keeping patients from needing inpatient hospitalization. Post-pandemic, and we're kind of moving into this realm of care, we're going to be focus back on that road to healing, maybe not as aggressive as we were pre-pandemic, but we're starting to kind of develop these wound care without walls sort of scenarios where we can continue to provide care with our patient, but in innovative ways. So patient education is key. I always say that an educated patient is a more compliant patient. Prior to the COVID pandemic, we had support groups that met at our hospitals, educational seminars, and even dietary seminars. But unfortunately, because of restrictions in large gatherings, we're no longer doing that. So as clinicians, we have to really be the one to help to educate our patient. And, self-care is very important, making certain that they are washing and inspecting their feet daily and doing their dressing changes. It's so important. I tell folks to check their feet daily. If they can't look at the bottoms of their feet because they can't reach down there, they can have a family member take a look, or they can even put a mirror on the floor and take a look that way. Glycemic control, of course, is very important. Patients need to check their glucose levels. They need to make certain that they're eating properly and getting appropriate exercise dependent on their ambulatory status. Vascular assessment. During this pandemic model, we see a bit of a higher tolerance for ischemia than we typically would post-pandemic. But vascular assessments, we normally would get, skin perfusion tests, TCOM, ABIs. Those are usually housed in the hospitals, so we're not sending patients as frequently and readily to these departments for those tests. We're really trying to pick and choose patients that have severe signs and symptoms of CLI before we refer them for vascular intervention and testing. We need to continue to evaluate and treat infection, but we're doing this, again, a little bit differently. X-rays, MRIs, things that are done in the hospital, we're also picking and choosing which folks we send for that. We're choosing dressings that might have antimicrobial properties. And unfortunately, if we can't do debridements as readily, we're doing some autolytic debridement or even enzymatic debridement. And where we would possibly have gotten cultures or biopsies in our wound care centers, we might just start treating these patients with empirical antibiotics that are broad spectrum that cover most skin and soft tissue infections, and we could do that via telemedicine. Offloading remains very important, especially in diabetic foot ulcer management, and we're going to delve into that quite deeply here in a moment. We want to continue to use the appropriate dressings dependent on the characteristics of the wounds and the exudate to control exudate and manage the peri-wound and wound tissues. And advanced modalities such as negative pressure or cellular tissue products we might not have access to currently because of the pandemic. So we want to be creative and use these judiciously in this patient population. So offloading, we know, is very important when we're treating diabetic foot ulcers. And you probably have heard the phrase, it's not as important what we put on these wounds sometimes as what we take off these wounds. So we have to decrease repetitive stress and eliminate plantar pressures. And there's so many ways in which to do that: wheelchairs, rollabout scooters, crutches, offloading shoes, removable cast boots, total contact cast. And these devices vary in effectiveness dependent on a lot of patient factors. But really what research has shown us is the most effective offloading is achieved when we use a device that spreads pressure and contact over a broad surface, and then we also really need to have patient compliance. A study looked at multiple different ways to offload the plantar surface of the foot. And you can see to the right of the graph, we have Canvas Oxford. So basically just your general use over-the-counter shoe. This shoe really decreases plantar pressures only minimally. If we follow the graph towards the left, we see some removable cast boots that were tested have some better offloading and pressure relief. And these were tested under that first metatarsal head. That's an area that we see highly subject for ulceration and diabetic foot ulcers. And to the very the very left of the graph, we see total contact casts. And total contact casts really do decrease plantar pressures the best out of all of these devices in this clinical trial that were studied. So how does a total contact cast work and what makes it so effective? Well, we know that there's a number of clinical trials out there that have validated the efficacy of total contact casts. It reduces plantar pressures. It's a hard interface, so the foot doesn't contact the floor. The cast does. It also helps to eliminate ankle joint range of motion. So the patient is not walking at a quick cadence and they're taking fewer steps a day when they do walk. It prohibits plantar flexion, so we're not getting increased pressures on the ball of the foot. And again, those are the most significant areas that we see breakdown for diabetic foot ulcerations. And it also transfers the weight from the foot to the leg, so it decreases pressures in that way as well. Because it molds to the lower extremity, it helps to decrease edema in the leg, which can also complicate wound healing. And we already talked about it. It decreases the steps the patient takes throughout the day. It is cumbersome. Patients aren't a huge fan of ambulating in it, and but overall, it will reduce the stress to the plantar surface ulcers. But probably the most single important and effective way that the TCC helps with offloading is that it has forced compliance. It's not easily removed by the patient. Now, it's not to say that the patients can't remove it, because over my 20-year career, I have seen patients remove them, but it's not easily removed by the patient. So there is that forced compliance. TCCs have often been referred to as the gold standard, but are they really? Because what we found is clinicians are really reluctant to adopt total contact casts into their clinical practice. Just last year, the International Working Group put out their update in their guidelines, and they do recommend a non-removable knee-high offloading device when we're treating neuropathic plantar ulcers. But a study was done by the U.S. Wound Registry that showed that only 2.2% of over 200,000 plantar surface ulcers were even offloaded at all. And of those, only 16% received a total contact cast. Over 30% were just placed in a surgical shoe. Now, surgical shoes really give absolutely no offloading to diabetic foot ulcers. In fact, I think they complicate things. I have patients have a hard time walking in just a basic surgical shoe. They slip around. I think there's some friction pressure that actually can increase plantar surface pressures and cause ulcers to deteriorate. The same study found that only 61% of clinics that were in the registry used total contact cast, and only 3.7% of those that actually had TCC eligible wounds, so plantar surface wounds without infection or without peripheral arterial disease, only 3.7% of those patients were even getting a total contact cast. So we're seeing that TCC, although has been touted as the gold standard, really isn't used widely among clinicians. The reasons why this is probably occurring is that clinicians might not have total contact casts in their offices or in their wound care centers or in their hospitals, so they don't have access to these dressings. They are expensive. They can be very messy to apply. It does take time. It takes time to apply the total contact cast, and it also takes time for the cast to dry. And there's concern for complications that, any areas of pressure, friction, hammer toes, bunions can cause rubbing. We've seen pressure, rubbing, or issues with lower leg rubbing, especially around the anterior portion of the lower extremity. And patients aren't a huge fan of total contact casts either. In fact, especially if the ulcer is located on the right foot, it can impede them from driving. They can't bathe or shower normally, and they have to wear it during bedtime. TCCs are also contraindicated in patients that have severe infection or osteomyelitis. They also need to have adequate perfusion. So typically, and this will vary depending on manufacturer, but typically you need a patient that has good perfusion, so ABI of 0.7 or greater. We also need to make certain our patients are fairly compliant because these casts need to be changed weekly or more often, especially in patients with heavily exudating wounds. So let's compare total contact casts with removable cast walkers. So removable cast walkers do have some tangible advantages over total contact casts. Removable cast walkers allow for more frequent dressing changes. So if a patient has a mild infection or a heavily exudating wound, we sometimes will use a removable cast walker in these instances because it allows us to have more access to the wound. Patients can remove the device if they need to drive or to sleep or to shower, but the problem is patients remove this device. So we don't have that forced compliance that we typically would see in patients that we use a total contact cast on. I've seen patients that are supposed to be using removable cast walkers at all times when they ambulate. I've seen them at the grocery store. I've seen them at the county fair, and they are not wearing their devices. I've had a patient tell me one time, Dr. Cole, all diabetic patients lie. And I'm not certain if that's completely true or not, but I have caught patients not wearing their devices when they should be. A study by David Armstrong found that only 30% of the time are patients wearing their removable offloading devices. So that's not a lot of time. That gives 70% of their day when they're supposed to be wearing these devices, they're not wearing them. A study also showed that when they compared patients with plantar surface diabetic ulcers and put them into three categories, either they received a half shoe for offloading, a total contact cast for offloading, or a removable cast walker, and they tracked wound healing over a period of 12 weeks. The median time to heal was significantly different. In total contact cast, these folks' median time to heal was 4.8 weeks, where the removable cast boot group, although all the parameters were the same, their median time to heal was 7.2 weeks, so about 3 weeks longer for the patients in the removable cast boot. And most likely it was because they weren't as compliant with their offloading. 3 weeks is a significant period of time because we know the longer that these ulcers remain open, the longer or greater chance that ulcerations can develop infection or other complications. So studies have shown that although the decrease in plantar pressure is very similar between total contact cast and removable walking cast, it seems that the forced compliance with total contact casts is the reason why overall wounds heal more quickly with this type of device. But maybe now we have the best of both worlds, and we're going to discuss my use of the VacoCast Diabetic. For clinicians that have been reluctant to implement total contact cast, there's now another option. And this is a removable cast, but it does have a locking mechanism for more forced compliance. So the boot offloads very similarly to a TCC. It's very effective. The lining is composed of a bead-filled insert that actually molds with a vacuum, very similar to the total contact cast fiberglass, but it's actually gentle and safe to use in patients with diabetes, and especially in those patients that have neuropathy or possibly peripheral arterial disease, because it's very safer than a total contact cast. The device comes with a washable, low friction insert. This is wonderful, especially for patients that have exudating wounds. So they can wash the insert and change it out so it prevents any kind of cross-contamination or reinfection because of exudate on the device. The liner also covers the toes, and this is a huge plus because it prevents debris such as rocks or sticks or anything else that the patient might come in contact with from getting into the boot and causing problems long term. We're going to skip the animation video, and we're just going to go on to continue to talk about my experience. The VacoCast has a locking mechanism similar to that of a TCC when it comes to compliance. So you can actually lock the boot. You can give the key to home healthcare nurses or possibly a family member or whoever is going to be doing dressing changes. Or in some instances, I simply lock the boot in my clinic and keep the key and just see the patient back weekly. So you have access to the area if you need it. Plus, again, that forced compliance. There was a community podiatry service in the UK, and they conducted a case series of 20 patients and they looked at utilizing the VacoCast Diabetic. And of these 20 subjects, 19 of them were diabetic type 2, all had plantar surface ulcerations. And what they found is there was no related injuries, and the device was highly comfortable and safe, and it continued to allow the patient to ambulate and go about their activities of daily living with minimum sequela. So here's the outcome to that study. And we'll see in those 20 patients with a plantar surface wound, they looked at these patients for 8-week observation period, and they only used standard of care or basic dressings. And what they saw in the end is 45% of these patients went on to complete healing. 15% had no change, but also 40% had some improvement in the wound, either a decrease in circumference, which were seen in 81.3% of the population studied, or an decrease in the depth. 52% saw a decrease in the depth of the ulcers. So it made a significant difference in a relatively short period of time in an 8-week observational period. And again, patients tolerated the device well, and there were no adverse events reported. Well, this device really fits into the pandemic model of wound care, because when we use a device such as this, we have less frequent face-to-face visits. So we can continue to use telemedicine to monitor our patients and maybe only see them every couple weeks or possibly monthly in our wound care centers and in our offices, but continue to monitor and evaluate them virtually. So wound care nurses or the patient or even their caregivers can unlock the boot, do the dressing changes and take photographs and send them to us so we can continue to monitor the patients virtually. It will also decrease length of appointment time. We talked about how total contact cast applications do take a lot of time. It takes time to apply the actual total contact cast, and there is a significant dry time involved in a lot of these devices. So this will decrease patient exposure to our clinics or our hospital wound centers, and it also decreases the face-to-face time and the proximity of clinicians to the patient, because when you're applying a total contact cast, you're really up close and personal with the patient for a long period of time. And we know with our social distancing rules of our 6 feet, and wearing PPE, we want to cut down on this close proximity. And utilizing the VacoCast will allow us to do just that. I want to mention that in the UK that there is a drug tariff reimbursement code for the device. So clinicians can easily access this by using the prescription, which is wonderful. I'm going to show you some cases of mine that I've had in the past several months utilizing this offloading device. And this was actually the first patient I ever used the VacoCast on, and really made me a believer right out of the gate. This is a 48-year-old male. He has had this ulceration for over 6 months. It's a neuropathic diabetic ulcer. You can see it's under the first metatarsal head. He does have a hallux hammer toe, so the toe sits up and causes retrograde pressure on the plantar surface of the foot. He is non-insulin dependent diabetic. He has neuropathy. We talked about that structural changes because of the toe placement. Prior to seeing me, he had failed multiple advanced wound care therapies. When he first came to see me, he was using Jensen Violet. I started him on collagen and put him in a total contact cast, but he was having difficulties ambulating in the total contact cast. And he also had feet that were hyperhidrotic. He was getting a lot of drainage. So you see he came in, he was having pain in the total contact cast. We removed it. We see a lot of peri-wound maceration. In fact, the whole midfoot there is macerated, and the wound is pretty significant. You can see the measurements on the screen there. So decided to switch him to an alginate and foam, and we transitioned him into the locking boot. And with him, I actually did lock it in clinic, and I actually kept the key. I saw him back 4 days later because I wanted to make certain he was tolerating the VacoCast boot well and that there was no problems with the wound and the wound was actually progressing in the proper direction. So I saw him back in 4 days and took off the VacoCast, and this is what the wound looked like. There was a significant change in such a little period of time. The wound measurement had decreased significantly and the maceration was resolving, and the patient was really happy. He was able to ambulate very comfortably in the device, and he had no complaints. So we continued, put the boot back on and locked it, saw the patient weekly, and by 2 weeks, this is what the wound had looked like. There was a thin layer of epithelial tissue covering the wound. Now, mind you, this wound had been open for 6 months, and in just 2 weeks, we had this wound essentially healed. So continued for 2 more weeks, and that's typically what I do. If I see a wound is healed or is almost healed, I continue for an additional 2 weeks in an offloading device before I transition them into shoes. So additional 2 weeks, he remained in the locking boot, and he came back, and we can see the wound had healed nicely. So we started to transition him into regular diabetic offloading shoe gear with an insert, multi-density insert. Patient compliance was not an issue because of the boot's locking mechanism. Patient tolerated the boot very well and was able to go about his activities of daily living without any issues. His functional status actually increased by using the boot over a total contact cast. Here's another patient. This is a 45-year-old female. She had had an intervention for a abscess on the plantar surface of her foot, and that surgical site had dehisced, and this had been open for 9 weeks. Again, she was diabetic. She's at an increased risk for having an infection, and once infection sets in deeply, oftentimes that leads to amputation, and we want to prevent that. So patient had failed many advanced wound care therapies. She had also been placed in a total contact cast, but was having lower leg pain. We talked about how total contact casts transfer pressure and stress from the foot into the leg. Well, sometimes if you have bad joints, knees and hips and back, you can have problems with these issues because of that transfer of weight. And that's exactly what she was having. She was having a lot of lower leg pain, shin pain, and knee pain. So she couldn't tolerate the total contact cast. So we put her in the VacoCast at this visit. This is what the patient looked like in 2 weeks. So she was utilizing continuous topical oxygen therapy and a dry dressing overlying the oxygen therapy. And the VacoCast was placed on the foot and locked, and we would see the patient weekly. And this is a 2-week period. We can see over a 61% reduction in wound area, and it really filled in nicely. Not only did the diameter of the wound also decrease, but the depth of the wound, and we see a lot of nice beefy granulation tissue at the base of the wound. Continued with topical oxygen therapy and offloading in the VacoCast, and patient went on to complete healing of this significant ulceration in 6 weeks. Again, no complaints of discomfort or any difficulties with activities of daily living. Here's another case, 62-year-old female, neuropathic ulcer, left heel. She had non-insulin dependent diabetes. She was obese. She had renal disease. She had developed an infection, taken her into surgery. I did an IND. I put a cadaveric skin graft on it for coverage. At this time, the wound measured 4.2 centimeters by 4.5 centimeters by 0.3 centimeters. I went ahead and removed those remaining staples for her surgical intervention. She was being discharged from the hospital, so she needed an offloading device and placed her in the VacoCast. And this is what the wound looked like 3 weeks with just a dry dressing and the VacoCast. The measurements had significantly decreased. The peri-wound tissue looks great. The wound tissue is nice and beefy, and granulation tissue is hardy, and patient was able to ambulate in the boot quite well. Continued decrease in wound size at 5 weeks, and wound healed in 7 weeks post-surgical intervention with offloading in the VacoCast with locking mechanism. Here's a patient, 56-year-old male, and this wound was actually on the lateral surface of his foot. He had a 7-week history of a non-healing ulcer. You can see his past medical history. Previously had Aquacell, and he had been placed in an offloading surgical shoe, which again, I don't think is the best offloading. He had come to me for a second opinion, and this is what the wound looked like at this point in time. So put him in the VacoCast diabetic and started good, aggressive, advanced wound care with him. And after a week, this is what the wound looked like. It was starting to close up. And again, we saw nice, healthy granulation tissue at the base. After 2 weeks, it continued to close down and get smaller. No problems, no issues from the patient. After a month, we can see the wound is very, very small, 0.7 by 0.8 by 0 centimeters in depth. And patient healed completely in 5 weeks, where he had labored with this wound for many months at another center. It just needed proper offloading that the patient could tolerate, and that helped to speed wound healing. So just kind of in conclusions, offloading we know is a crucial part of standard of care for diabetic foot ulcers. Researchers and consensus bureaus have long considered total contact casts to be the gold standard, but there is a gap in clinical use, and fewer than 2% of wound clinics in the U.S. are using total contact casts for a variety of reasons we have discussed. So there needs to be a better way to offload these plantar surface ulcers, and I think we have one now. It's a VacoCast, and it kind of gives us the best of both worlds. It allows us to have access to the wounds when needed, similar to a removable cast walker, but because of that locking mechanism, we have that forced patient compliance as well. So I think it's the answer to a lot of the questions that we have as diabetic foot ulcer treating clinicians. And it really fits in the current pandemic model of wound care great. And I've been using it. In fact, I put 3 patients in them this week. It really bridges that gap. It allows for ease of use as similar to removable cast walker, but that forced compliance that we need for these patients. Randomized controlled trials in a larger sample are needed to validate my experience. And in fact, my research center at Kent State University College of Podiatric Medicine will be starting a randomized controlled trial comparing the OPED VacoCast to total contact cast, and we're going to look at wound healing parameters and then also a functionality of patients in a pilot study, and we should be starting that probably next month. Here are some references if you wanted to look up some of the studies that I related to within the presentation. And then finally, here's my contact information. If you have questions, you can email me or call me. I'd love to collaborate with colleagues, especially on difficult cases. So that'll do it for me. I think I might.
I'm here. Thank you, Dr. Cole, for an excellent presentation. And I can only apologise for the IT issues. Just to point out, the CME report has since been published in the Diabetic Foot Journal. Yep, fantastic news. I would now like to use this time to open this time for questions. So the first question to Dr. Cole is there a reluctance to use TCC due to lack of skills?
Well, there is a learning curve for sure. So I think that patients or clinicians are kind of reluctant to use it if they've never used it. I would say, you do 5 of them and you could probably put them on pretty quickly. But yes, there is a learning curve and there's a reluctance to use them because of that. Are you there? We lost Mark. Modern technology. I'm going to try to look through some of the chat and
I've
just
got
kind of.
I've got a next question.
Okay,
So,
okay. I
do
lost you there for.
do you use a step down approach once healed, i.e., continue to use a TCC or a boot for 4 to 6 weeks, then a temporary shoe with orthotic, etc.? May this
Yeah.
reduce the high recurrence rate?
Yeah, and I did mention that during the presentation that once I see that the wound is healed, I continue to offload for 2 more weeks. So in that particular case, the patient, even though clinically it looked like the wound healed, I continued him in the VacoCast diabetic for an additional 2 weeks, and then I transferred patient into a diabetic shoe with a multi-density insert for continued offloading. So yes.
Thank you. Next question. Have you used VacoCast diabetic for Charcot?
I have not. I don't see a ton of Charcot patients, but I have not. But I don't know why you couldn't.
Would it be something that you'd also use for non-DFUs as well?
Oh, definitely. Yes.
Brilliant.
Well, for any plantar surface ulcer, be it surgical or, a non-diabetic traumatic ulceration. So anytime you need to offload a plantar surface ulcer, this would be a great mechanism by which to do so.
And I've got another question. Is there any role of VacoCast in Charcot foot?
I think so. Yeah. I mean, again, I haven't personally used it, but in Charcot, the hallmark and the cornerstone is offloading. So this would be a great way to offload a patient, especially in the early stages of Charcot. So yes, I think it can be used. I just personally have not.
Okay. And how long should you keep the boot on once it's being treated, the DFU is being treated?
You mean during the day or how long?
Yeah, during the day.
So I've locked these boots. I think that's really the benefit of them is that you can lock them and unlock them. So you can unlock them to access the wound if you need more frequent dressing changes. But again, locking them allows for forced patient compliance. You don't have to use the locking mechanism. If you don't use the locking mechanism, then the patient would remove the boot when they're non-ambulatory, remove the boot to shower, and they remove the boot to sleep and to drive. But I think that in this patient population that I've been using it on, I do lock them to have that forced compliance.
Thank you. If a patient has a height discrepancy whilst wearing the boot, how would you combat this?
Well, I often use an even up to place on the contralateral limb so that it helps to offload and stop that limb length discrepancy from occurring. So even ups are very, very helpful. In fact, I just asked for a couple more from OPED this week because I patients in the VacoCast. So they've been very helpful.
And if locked, how do patients sleep or shower?
They sleep with it on and they shower. They either take a sponge bath or they use a cast cover, similar to how they would sleep or shower if they were offloaded with a TCC. And I've had no problems with any of the patients. A cast cover for a shower runs $20 US. So they're inexpensive.
So we got a question on, just to elaborate, what is an even up?
Oh, okay. Well, Even Up is a device made by Head as well, and it fits on the bottom of any regular shoe, and it helps to even the discrepancy of limb length that you can see with patients wearing the boot similar to this or even a total contact cast. So they're very helpful devices. Patients can take them on and off so they can use different shoes for the contralateral limb, but it could stop that limb length discrepancy and prevent problems with like back pain or hip pain that we can see when patients are using an offloading device.
Thank you. And how do you prevent ulcers reoccurring after being in a boot?
Well, what's very important long term is transitioning these patients into appropriate shoe gear and offloading devices. So I work very carefully and very closely with my podorthist, and I get these patients into some sort of offloading, usually a custom orthotic, to decrease pressure points and offload patients in extra depth shoes so that there is decreased rubbing and friction. And you really need to educate your patients. They're really not to walk barefoot or in socks or in thin-soled slippers. They need to have good accommodative shoe gear to prevent recurrence.
Another question, is there relevance to offloading DFUs during the COVID-19 pandemic?
Well, I think we need to offload diabetic foot ulcers regardless of what's going on. So this is a method by which we were able to continue to offload during the pandemic, and offloading is key. Again, we always say it's not as important what you put on these wounds as what you take off of them. You still have to remove those stresses, those plantar pressures, in order to allow these wounds to heal. So offloading is key during the pandemic and beyond. And I think that the VacoCast has been very helpful in my patient population to continue to do this and to do this well.
And would you re-vacuum the boot at each visit if changes in the limb?
Yes, I do. I re-vacuum it at every visit.
And can the boot accommodate dressings?
Yes. Yes, there's quite a bit of room within the boot to apply a bulky absorptive dressing.
We're just waiting for some more questions. What we could possibly do is actually show the video. Is that okay?
Yeah, now I have to go back up to video. Or is it? Or you can.
So you can close it.
Okay. And is it the AV view?
So we're going to go into the vacuum function.
Okay, you're going to do it? Okay.
I'm going to do it. So I'm just going to press play. Hopefully everyone can see this. So for every single VACO 12 bead, it has 12 contact points. This results in almost indefinite number of possibilities for adaptation of energy redistribution. These 12 contact points pass on the energy multi-dimensional to the next 12 beads. So in essence, basically, the weakening of the energy is then again passed on via the next 12 contact points. So there's no need for inserts, insoles whatsoever. So we can guarantee there'll be close contact support anterior, posteriorly, medially, and laterally. So the beads will safely conform to the bony prominences, metatarsal heads, malleoluses, heels, and the arches of the foot. And I have another question. Okay. Is there any study about, NPWT plus VacoCast in combo?
I don't think there's any study, but I don't think that there would be any contraindication in using negative pressure. I've always used negative pressure with removable cast boots and total contact casts. So I have yet to use it currently with this device, but I don't think there's any contraindications, and I think actually it would work very well. Typically with negative pressure wound therapy, we change the dressing 3 times weekly. So if we had home healthcare nurses coming out to do that, or if we had the patients coming into our centers to do that, we could simply lock and unlock the boot or give the key to the home healthcare nurse to lock and unlock the boot. So if we chose to lock it, we can definitely use negative pressure. If we chose to keep it unlocked, we can definitely use negative pressure. So I think it would work very well together. 2 of my favorite things, offloading and negative pressure therapy.
Fantastic. Thank you very much. There is one more video I would like to show, and it's a simple application on how to use the boot. I'll just quickly show it now. Unfortunately, this video is also on mute. So it's a very simple procedure. It only takes about a couple of minutes, and as you can see, it's completely different to a pneumatic boot. So as you will see, as the application goes on, you'll get support from every aspect of the limb. So, we're around the arches of the foot, which is fantastic for Charcot, but also medially and laterally. So you can build up the beads wherever you want, where you feel it's necessary to get that additional support. So the actual bead liner that you can see there the liner is actually a velour liner. So additional comfort for the patient. And what you want to ensure is make sure the heel's all the way back into the boot. So as you can see there, it's got a little toe protector, so it actually prevents any stones or chips going into the boot. Has a 3-panel backing, so allows a bit of muscle movement, so it's not as rigid and unforgiving as a TCC. So you're less likely to get muscle wastage. And what it doesn't actually show, you can extend the foot plate. So they're caught in between 2 sizes, you can extend that foot plate. They come in 3 different sizes, so I apologize for this. So for UK sizes, they accommodate for people from size 2.5 up to size 14. So for most patients, it will cater. So there is a strap sequence. So S1, that's your priority strap. And there's 4 straps. So every part of this boot is interchangeable and replaceable. So rather than changing the whole boot altogether, what makes this unique from other boots on the market is you can just switch the parts. So if the Velcro goes or the sole goes, which comes with a spare sole as well as a spare liner, it's more cost effective. And as you can see, it's vacuuming the air out of the liner. Okay, we don't appear to have any more questions, but what I would like to ask Dr. Cole is there anything else you'd like to leave with the audience today?
Well, I think these are unprecedented times. We've heard this many, many, many times, and we're looking for innovative ways to continue to care for these very fragile patients. And so things that can fill a real needed niche, such as the VacoCast, are a godsend to clinicians and patients, because it's helping to keep these patients back on that road to healing and prevent negative sequelae such as infections, amputations, hospitalizations. So I think we're looking to the future, and we're going to see a lot of changes in medicine and in wound care delivery, and this really fits into that new algorithm of patient care.
Thank you very much. This concludes our webinar, but I'd just like to remind you that you will receive an email and a link with this for this webinar and a certificate where you can collect CPD points. I just would like to thank Dr. Cole and the audience and apologize for the technical issues.
Thank you, everyone. Thanks for joining us.
Thank you.